she really need introduction. She's a well-renowned injector and she's a global key person, very, very important person. And she's innovator. She's very creative. And she always, amazed me coming with always, a new idea and everything is so interesting, coming from her. And today I'm sure that she's going to give us shed the light or, giving her bright idea on how to make, people look beautiful and focusing on the mid face. So please welcome Dr. Kate Godis.
Hello, Achima.
Hi. Nice
Hi.
to meet you.
Oh, good. Thank you so much. Thanks very much for having you. And it's always amazing to work with you for so many years, Achima.
Yeah.
Honor to be here.
Lovely to see you. And at the moment, Thailand is kind of cold a little bit. So it's very cool in Thailand at the moment. Very cool too here. Yeah.
Great. That was it. It's funny, isn't it? It's not what I think in my mind when I'm thinking about Thailand. It's like, that's nice. It's actually nice to have a cool time there, isn't it?
Yeah, absolutely. Yeah.
We have so much cool, we don't know what to do with it, especially now. It's very cold now. It's coming in. Yeah.
So what's you going to bring us today? I'm so excited to hear.
Thank you, Achima. Well, I'm going to just now share my screen and one of the, I'll just come back to this one actually. You can see that, Achima? Can you? Yes?
Yes.
Yeah. Over the years, Achima, you and I have talked many times about how the big pictures in aesthetics and how we can rethink some things. And I think some of the hardest things to rethink are when things are very familiar. So in this just talk today, this is my aim. My aim is to think about the concepts of the mid-face, what we're good at, what we're not so good at. Think about how we use the bilateral products, and particularly I'm going to focus on bilateral volume. I'm also going to think about how we might do a little bit of combinations, how we compare that with therapy, in that same concept that we have about the mid-face. And for me, before we even start on the details, there's a system that I think is really important when we think about treating our patients overall, and a very important question that we always start with, or we should really create an image in our mind. And sometimes I realize that I haven't been really clear about visualization of aesthetic goals in my own mind. So we want to ask ourselves, what do you actually want your patient to look like at the end of this patient? Not anyone else, but this patient. So for me, especially with the mid-face, like I need the mid-face to play a strong role. So when I see my patients, I see before and after. I see when I turn my patient before, I need to create more symmetry. I need to allow that patient's face to be more balanced. That's a really important thing. I need the eyes to be framed better, sort of, in terms of the overall structure of the face. And those things are really clear in my mind. In addition to that, I need the mid-face to be able to support the lower face. I want it so that, like on this patient, I want it so that the mid-face will frame the eyes better, from here on my left and then onto the right for the after. I need the mid-face to play a strong role in slimming the lower face. But I also don't want it to make that face look any broader. And those kind of very straightforward aims of the mid-face are something that we do kind of focus on. And we're going to look at the details of how we do that. I also need the mid-face to be able to move naturally. I need the mid-face to be playing a key role so that that person, when they move, this is a before and after for this lady, but when she moves, that I need her midface. And when I say her midface, we're going to talk about those concepts about what really do we mean. We need it all to move together. And this is tricky. So far I need more symmetry, I need framing of the eye, I need it to slim the lower face, but I also need it to move not just naturally, but I need it to move together and look younger. And so as we think about this together, I think that one of my challenges is to say that when we think about the midface, we have traditionally looked at the midface in terms of beauty. And for me, I've been like really trying to think of the midface in terms of youth, creating a youthful look. And in addition to that, when we use language, and it's because we're all doctors, that we like language which separates things. So for me, I don't really mean this, right? But what I'm going to say is that I don't believe in the midface. Like, I don't believe it's a single area, because I think if we too much focus it on as a unit, we forget that for me, the most important units is a whole unit which connects the lateral face, the temple, the supraauricular, and the preauricular. This, for me, is one system. This is a thing in itself that is more useful as an aesthetic unit than an aesthetic nomenclature than the midface. So it's just a way for me to move out of my groove that I think the language helps me jump. So how can, when we think about we're still going to call it the midface, but how can we look at the systems of the midface and the surrounding systems, and how we analyze it help us improve our outcomes? Now, I'm just going to take you through some basic anchors, some basic landmarks, which I think are extremely important. Not everyone, but just the big players. So here's the big players I think that can help us improve our analysis. So in order to understand what the big players are in terms of outcome, so by big players, I mean, what does this patient have unique to them? What are the big players that will make a difference in what they look like afterwards and how easy it is to achieve that outcome? So to do that, you need to think about our eye. What habits does it have already? Now, I say this for myself, right? These are the habits that I sometimes am trying to encourage in myself that I didn't always do. Number one, I want to make sure that my eye sees all of the shaping and contours of the real lateral face. Like I want it to see the types of transitions that it comes across. I want my eye to see the orientation of the cheek, that I see that the anatomical cheek and the visual cheek is different, that the older cheek and the youthful cheek has a different orientation. I also want to understand that in order to be able to make things look natural and for all to move naturally, that when I augment, I need to augment continuous augmentation. If I want that kind of result, rather than spot augmentation. We'll talk about it more later. And then also I want to make sure, and Achima particularly has helped us in this with her studies over the years, to really see beyond the face, like to really make sure that we use the non-facial spaces in different ways, but also that we see the actual transition from face to head. Like we actually see the transition, because our subconscious sees the transition, for sure it does, but our conscious eye quite often misses it out. So people look older, but we can't really tell why. Now, again, the big players in visualization, again, when you're trying to see what's going to make a difference in how we treat the midface, would be Facial structure, we're going to look and see how the bones make a difference. Again, you just need a few anchors to help you change the outcomes. In particular, we're going to look at the zygoma and its relationships, to the medial, to lateral, to above and below. We're going to look at soft tissue transitioning, and we're going to look at the concepts of horizontalization and verticalization, and how they are really key to creating youthful midface. Here's 3 ladies for you. And these ladies are, as we work from left across to the right, they are 30, 40s, and 50s. They are English, Scottish, and French. And they represent different uniquenesses in their structure, and they also have similarities. So it's really important that we orientate ourselves and see, when we're looking at the midface, how we might want to treat those people. So one of the main ways that we would like to orientate ourselves in terms of structure, we would, for me, one of the big players is just trying to understand the dimensions of the face. So our younger patient, Lauren, her facial height, which is hairline to menton, compared to her bizygomatic distance. So bizygomatic distance for humans would normally be about 75% of the overall facial height. Now, the longer the facial height is comparison to the bizygomatic distance, the more long that face is, and she is more towards the longer. Why is that important? Why is it a big player? The reason it's a big player is because I know that I can widen her face and maintain a natural look. Now, when we go here and we see with Shauna, who's in her 40s, you see her lower face has started to get fuller and heavier, but also she's rather towards the longer, but the lower quadrants have started to get heavier in general, but we also know we can use those lateral structures. But what happens when you come to our French lady Valentine? Now, the Valentine is much more shorter and squarer. Her bizygomatic distance is broader. Now, the tendency when we look here and we think, okay, she's already broad, and I know when, depending on the patients that we see in Asia, we have many patients who are broader in the zygoma. And so therefore, we look at them and think, we cannot make their face wider, otherwise you make it more square. So we need to try and avoid this bizygomatic, the sort of lateralization of the face. Now, but what that means, I think, is that somehow we maybe have not used that, and including for my Caucasian patients as well, for this type of patient, we haven't used those spaces cleverly enough because you can really create slimness with the face without creating width to the face. So for me, it's really important that we look at the detail, especially of the last person here, so that we can use the mid-face to flow and support it, slim the face, and not neglect it. So use that area. Sorry, I'm just going to move my pin up to here. So next, another big player. I always like to have my visual aid here, because it really helps your brain to understand in 3Ds when you have a little skull beside you and you remember that these are the bones that you're using all the time, you're injecting off them all the time, and it reminds you of the orientation. So remember, the zygoma relationships that we're going to focus on is lateral zygoma to medial zygoma, and you're asking yourself, is this straight or is it slanted? As in, is the medial zygoma, like we see in Lauren's face, does it really sit a lot more medial than the lateral zygoma? That's really important, because as you see here, this with Shauna, she shows what happens if you have a weak medial face. You have a lot of buccal ptosis, medial ptosis. This is rather exaggerated slightly, but with our last lady here, you see the relationship is much more broad, much more straight. And what happens is, of course, and it's built with our Asian patients as well, is that the step off into the mid-face is more direct. But overall, what happens is that this distance, this medial bizygomatic distance, creates different relationships of all the medial structures. And we need to be able to use that space to maximize it as we move through an analysis of the face, because this tells us how that face is going to age. Lastly, before we move on, it's to do with the horizontality of the cheek. Just look again at the shape of the zygoma. The shape of the zygoma is a horizontal buttress of the face. It is completely straight. It's horizontal. So no matter what we do, if we only inject on the bone, we will only ever create a cheek which is like a horizontal cheek. Now, the cheek of youth is verticalized. The cheek of aging is horizontal. Now, we see this horizontal shapes much more when we have descension of the deep fat pad. So the extension of the buccal that comes underneath the zygoma, as that decreases with age, as well as more superficial tissues, you gradually see this more horizontal in position. And this is, of course, another reason why if you have very strong zygoma, then people generally, when you have Valentine strong horizontal zygoma, we leave it. We just don't do anything with it. But it will still look horizontal. And the problem is, it's a big giveaway for age. So you might not want to touch it, so you don't make it broader. But in actual fact, you need to change the orientation of it. And we'll look at strategies where we can make this more youthfulized cheek. And lastly, we're talking about analysis and what are the big players in analysis. Lastly, it is just allowing our eye to make sure that we consider how the face fits with the head and how your behind the hairline is not, we see that in different ways. We see the transition. So with the younger person, it flows straight back. You know, as you get older, it's starting to dip before it comes into the hairline. And with Valentine, who's older, this is really a large dip before it comes into the hairline. What that means is we have to transition as well as potentially using that area for lifting as well. So if we think about that, the way that our analysis can help us get the best result, the way analysis does that is that it makes good analysis, makes sure that we look at the same area from different directions. So you're looking at behind the hairline and the temple to look at transitions and then loss. And those do different things. Volume loss, you can use it to lift. Transitions, they will be used to make the person look younger. So then, what is the aim of my treatment? Very simply, when I'm looking at this area as one area, if I want it all to be one area, then what I need to do is I want every single part of that area to look younger. And that's my aim. And the second is I want every single part of that area to look more firm. Because if you have one without the other, it doesn't really work. So that's the very basic aim of my technique or my treatment. Excuse me. So in order to be firmer and younger, I have to do two things. Number one, I have to make sure that I am free from the bone of the midface, yeah? And make sure that the tissue planes that I use are not on the bone. So we're just taking that broader faced person who has a broad, straight zygoma. And what I need to do is I can't use the bone, so I need to use subfascial. So I'm going to use this mass in this case. And I also need to be able to really work on the retinacular fibers in between those two layers and a subdermal position. So to make it move naturally, I need it to be under this mass. To make it be firmer, I need to be able to treat this mass, treat the fascial layers, as well as that subfascial layer. We'll talk about that as we go along. So this mass, of course, is very useful for our aim. And the reason is because it, as you see here, it flows right past the bone. It's an anatomical plane of which you can create shapes which are not horizontal. You can create vertical shapes because you're past the bone. The products that we said we were going to use is going to be Belotero with CPM. Why is this important product for this area? Because it is made in a special way. The first phases, which you know, is just basically hyaluronic acid, BDDE, mix it all together. In the second stage, where you have the hyaluronic acid and plugs of free hyaluronic acid in there, and then you get this natural collections of BDDE, which gives you a morphologically natural gel, which integrates in, but it also moves with the tissues. And that's really important, because if you have this combination between integration and cohesivity, then the combination of those two things, for me, does something different than simply allowing aliquots of gel that sit within the tissues. It does a different thing to the dynamics of the tissues. Now, normally this integration is important when we look at superficial planes. So here is a study done by McKeel's where you show the difference between Restylane, Juvederm, and Belotero balance here, and we see integration. Now, normally we've said this is important, this integration. Why? Oh, because we don't see it afterwards. And also the fact is that we can inject it really superficially. But if you think about all those tissue planes that we're interested in injecting, intradermal, fine, not so relevant for the midface. Subdermal, why? Yeah, because it flows, it goes past areas which are going to hold me in one anatomical plane. So subdermal is going to be brilliant for injecting the temple, but also in the suprauricular. So we're going to use it there. Then also subsmas, that's going to be a good area because it flows past the bone. So this double layer means that we can create a single sort of beyond the midface useful augmentation. And what it's going to do at each layer is it's going to completely integrate in with the tissues. And what that does, in my experience, is that it creates a different dynamic structure to the tissues because it's cohesive and it's integrative. It creates different dynamic outcomes. And that makes the tissues move differently. So when we saw that patient at the very end, remember, for me, that's the big giveaway. It has to be, it's not just because you can't see it. Integration is not just about that. It's the fact that it becomes part of the tissues, and those tissues have different dynamics when they're there. So we think about different planes, and we're thinking about the midface, and we're thinking about going beyond the skeletal structure and creating sweeping single continuous augmentation layer by layer. The fact that it continues on for me is really important. It's like the magic thing is the fact that it doesn't stop at the end of the midface. It's the fact that that stronger tissue flows right back. When we looked here in our study to see what shapes you make and what augmentation you can from deeper structures to more superficial structures, in this case, we injected on the bone in the first one, and then at the same time, we injected subdermal. And you can see that subdermal position, it gives you a lot of volume. Yeah, so this was 0.6 on the bone, and you see that straight angle. Yeah, it's very just like a blade as you copy the position of the zygoma. And then this is the volume. And then when you go subdermal, yeah, you can make all sorts of shapes around that. And also you get more volume with your subdermal 0.4 than we did with our deep 0.6. So the subdermal plane, and this was maintained after 3 months here. So the subdermal plane is very useful for creating dynamic, continuous shaping. But if you only just stop at what we call the midface, I don't think you make people look younger. I think you can make them look better, and you do make them look younger, but not profoundly younger. Profoundly younger is the continuous sweep. When we looked at when we've injected people in this way, we looked at subdermal placement under ultrasound. We looked at that at the subsmas. And we noticed that after a month, everything is extremely well integrated. Subsmass, sometimes you can see it under ultrasound if you really target the SMAS. You can still see some of the product. It's integrated well, but some of it's still visible. The subdermal placement of bilateral volume is entirely integrated, but with maintained volume, which is really important. It didn't go away, it stayed there, but it's completely integrated. And it's a very voluminous product, but completely integrated. And our idea is that we would be able to create more sweeping cheeks. This is just on a younger person. This is a half face done here, where on the treated side of the face, which is on the right-hand side, we just have a very subtly nicer framing of the face. It lifts the gel at the bottom, and her cheek sweeps towards her hairline, while it's on the other side. So we have a cheek sweep. One of my patients said that it looked snatched. It looked like you put your hair up and then it just kept everything sweeping towards it. It means that the lateral part of her face smiles, whereas on the non-treated side, everything is more straight, and you know exactly how this person is going to age. She's going to have a lot of verticalization and a lot of vertical structures. So how would we physically do on older people, much more challenging people? How will we approach this kind of continuous augmentation that goes from the midface into the temple and up into the supraauricular zone? So we're going to focus on the SMAS, injection of the SMAS first of all, but also think overall what areas might we augment. So we're going to do subsmass. In general, often I would only go up into the temple at this position if it was in the anterior temple. The lateral, the posterior part of the temple, because of the transverse fascia and also the presence of nerves and vessels, I think is often better treated from coming from a cranial to caudal approach. But the cranial to caudal approach, for me, it doesn't make the same shape or movement than a kind of horseshoe subsmass does. And as you see here, we're going to step back from the zygomatic cutaneous ligament and leave at very least 1 to 2 centimeters back from that. Preauricular, even on wide-faced people, the preauricular area subdermal can create slimness into the face and not heaviness, depending on making sure that we target that pre-mesenteric space. And then also looking at the supraauricular area, the specifically supraauricular area in this case for local structures, and looking how we can use those local short vectors to create different structures, and that being a continuous connection between temple, supraauricular at a subdermal position, and then a subsmass position as we move down into the midface. And again, when we think of this, our aim is not to broaden people's faces, it's to slim it. So we use each of these spaces to do that. Now, thinking about subsmass, we're going to inject the subsmass now. We're going to look at injection technique there. But what we have to do really is think about everyone's SMAS is different. And it's just an example of between the older lady who's 60 and Valentine who's 30. Look at the difference in her, this is mid-zygoma, so it's there. Valentine has had a facelift. You see all her SMAS there, very dense, going to be hardly any fat above and below it, compared to this much more easy to see structure where you have these lovely big fascial SMAS structures and this linear arrangement that you get in the lateral face. Things are not so linear when you come to the medial face, but this is a nice linear structure that you get in the lateral face. And the reason why I always go in at that position is because you can really tell where you are when you're in the lateral face. Medial face is harder. So let us, first of all, create that horseshoe beyond the mid-face SMAS augmentation, which will move into the temple, so it will go, because as we know, the SMAS is continuous with the temporal parietal fascia. And we're going to use that connection. Here's a 21 gauge needle. We're doing a little port site. It's at least 1 centimeter away from the area that I want to dive deep under those linear fascial structures. So I'm giving myself space to get to the right depth. This is subdermal, so I'm giving it a little check. Watch my non-injecting hand here. Look how I'm protecting the eye. And now I'm going to sense this mass, give it a little bounce, 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 roll it. Now, the most important thing here is that I'm not trying to go to the periosteum. This is a subsmass augmentation. And what I'm doing is I'm cantilevering, so bringing my cannula up, and instead of trying to place deep, I'm trying to place superficial underneath this mass. So I'm under this mass, and I'm putting tiny amounts, pulse, move, pulse, move. There is me up beside the orbicularis retaining ligament. So I'm not just supporting this mass, I'm also making sure that this angle where her medial zygoma is, that we soften that angle and allow that to sweep back. So we must go up to the ORL as well as place it underneath this mass. So this is for that broader face person that they want to slim. When we do that, if you just stick to the shape of the bone, you just make it broader. But what we're doing is making sure that we tip it above the medial zygoma here, which is in that position there. So we line it there, and then allow the horseshoe to sweep up. So tiny, tiny amounts. The most important thing that I have in my mind is that should be continuous. It's a continuous integration to change the structure of that tissue, and you can't do it from one point. I'm doing pulse, move, pulse, move, pulse, move, running around all the time, making sure I sense where I am. Now, we can look at this under ultrasound and look and see what happens. So here, I know it looks like a lot of black and white. There is this mass above it. You can see my cannula moving. You see it's not on the periosteum below. It really is just underneath the fascial structures. And there is that big blobs that sit there. It's having that vision in your mind, because the details make the difference. If you point your cannula down, you will literally just inflate the deep fat pads. If you bring your cannula up, then you really do an immediate subfascial augmentation. That, for me, just looks different. The outcome looks different. And the other thing is, as opposed to if we were injecting on the bone, when we inject subsmass, you need to integrate it mechanically afterwards. We can see the difference when you look on the ultrasound. If you don't mechanically integrate it, it means that you squash it. You mechanically integrate it is a posh word for saying squash it. This is really important. It's almost as important as how you inject it in the first place. So for that subfascial augmentation, with this case, we use bilateral volume, we use 22, we use 1 to 1.5. We're not broadening, and we didn't broaden it because we swept it past the cheek, and we made sure that our augmentation is up to the ORL in that little kind of triangular space, which helps to narrow the face and not broaden it. So now we're going to think about the supraauricular area. And as we move back, because we're going to insist in our minds that the mid-face and slimming all of the inferior medial structures requires us to have continuous augmentation in the lateral part. What do we have to be careful of? I know you know this anyway, but just remind ourselves. We're going to switch to subdermal. Again, Ashima, as you will know, has published a great paper on augmenting the supraauricular area in a subdermal position. So we're thinking subdermal seems like a good position. Why? Because, of course, in all of that structure here, the major vessels which are coursing across are all integrated and fairly protected by our superficial fascias. So in this case, the superficial temporal artery will be sitting and protected by the superficial temporal parietal fascia, which is also continuous, as we said, with this mass. So we know it's there. We're going to be very careful about it. We also know, as you go back across in these supraauricular areas, we also know that we have frontal and parietal branches of these superficial vessels, and they also have an unbifurcated section. So therefore, as we come just above the ear, we're careful that we need to make sure that all these arterial structures which are protected by our fascial structures, we never go near them. My learning when we look at the ultrasound is, for example, in the parotid, we're like, yeah, I never inject the parotid. I'm never anywhere near it. It's protected by the fascial structures here. But in actual fact, when we look on the ultrasound of lots of people who've had hyaluronic acid fillers in this area here, lots of people have hyaluronic acid or radius in their parotid. And one paper came out and said that 70% of parotiditis at the moment is caused by fillers. So what that says to me is it is easier to cross planes even with big cannulas. That's the reason why we're using our 22 gauge cannula. It's easier to cross planes than we think. So here, if I'm going to inject that supraauricular zone, and in this case, what I want to do is I want to create a continuous plane, because it's to do with the mid-face and local structures. So my technique at the time will be, I want all of the area to be augmented, but in addition, I might also want to transition. So the amount I leave in each place will be different. If you want to transition, you leave more in the space between face and hair and less as you flow up. In addition to this, what I found, which would be interesting to chat with Ashima about afterwards, which is I've done this augmentation where you do this continuous plane, and then in addition, do Ashima's technique, which is that published technique of using a larger bolus almost together. So you have transition, integration, continuous direct tissue augmentation, plus specific and direct vectoring of lower face. It's been a nice, some nice results in terms of youthification of the face. So just drawing our attention to the real, the details, right? Sometimes we speed these videos up, but for me, when we speed them up, we miss the truth. The truth of it is that when I am moving within the tissues, I am injecting extremely slowly. I've actually realized you can almost, I'm not suggesting you do this, but you can almost do it better with your eyes closed, because what you really need to do is with your non-injecting finger, you pull the cannula up all the time, and you should feel the tip all the time, the whole of it all the time, because it's very easy to go deeper. And let me show you how easy that is. So you feel the tip. I always say you should inject like your grandmother. Now, as in she would inject, I would imagine, maybe not my grandmother, she was always very fast, but she would inject really slowly. No fast movements here. There's very, very, very important vessels sitting underneath your tissue. Here's one. This is the superficial temporal artery here. And see that little bit there? That is me moving my cannula. There is my cannula. That's the tip of my cannula there. This is the superficial temporal artery sitting within those fascial tissues here as it's moving up. There's the temporal space here, and it's moving up towards the supraauricular space here. And as you see, all the tissue planes are coming narrower and narrower, and my cannula is sitting over the temporal artery. Now you see there's not a lot of space. In fact, this is my product that's actually coming underneath it. So it's spreading underneath that tissue. So that's fine, but I need to maintain that space, and I need to make sure I stay there. It's not a lot of difference between me and that artery. Now, the tactile feedback and being very gentle, very slow, these are, for me, it's just everything. It's success and failure, slow, gentle, and always checking. And the other little trick I have is that, or the way I've thought about it is, if you look, right, get one of these skulls, and you think that when I'm coming up into the supraauricular zone, it feels like that. When I look on myself or when I look at my patient, that looks like it's a straight line, but it's not. There's a big hill here. And if you just expect your cannula to go straight in front of you, you always go too deep. So what you have to do is keep pulling the tip of your cannula back all the time, because what you're doing is you're actually making a straight thing climb a hill. So for me, in order to be treating this gray area, which is we're watching our evolution of how we treat this area. But we need to be careful. This is afterwards. This is just an example of, actually, it's our French lady here. Remember how I was saying that you may want to transition one bit and integrate with the other. So as you see me moving around, you'll see there's a thicker bit of product, and then it thins out into integrated product. So in fact, I had put all of the supraocular area, which, as you see immediately, is completely integrated, but you still see product because that is actual volumization. That bit there is the bit which I filled up so that her face was going to transition evenly with her hairline. And if I didn't, then I would lift it, but it would still have a dip. So these are two different outcomes we've done with the same technique: transition and local lift. This was, rather than long lift. Again, for me, 22 cannula, essential, because otherwise too easy to swap planes. Think about within those areas, you can really create different vectors. We're going to think about this with all therapy later on. Finally, because I want it to be a continuous plane, I'm going to put small amounts of bilateral volume subdermal, many passes, so twice as many passes as I think, with half as much product as I think. And then the reason for this is not just volumization, it's to create this different tissue texture and lift as we move across. As you see, she already had a bit of asymmetry before, but you definitely get more of a lift on one side as we do all of those zones, from subsmass to subdermal to temple to preauricular, and we augment her across her face. So lastly, as we're coming into the last bit now, we might think about how we would, in addition, combine that with all therapy. So just have a couple of slides about that. For me, I do exactly the same thing with my therapy as I do with my hyaluronic acid. And that is, I really think about these local vectors. So when we look at a patient, again, it's like I'm focusing on this youthful face. So in fact, my mid-face therapy is my upper face, my mid-face augmentation is my upper facial therapy, basically, because it's this bit I'm focusing on. I know there's other complexities to the mid-face, but let me just see, these are the most important bits that I would focus on if I want to create a more youthful cheek. So we have our different transducers, as we know. In this area, for the youthful cheek and the youthful mid-face, it's the most important tissue layer for me is both the fascial structures, but importantly, making sure that we get the retinacular that's in the immediate subcutis. Like, they are the ones that create that firmer tissue. So we want contraction, but I find the contraction, when you have very strong fascial tissues, it can work extremely well. But if you don't catch that immediate subretinacular tissue, which is very different positions in different people, then I just don't get the same firmness of tissue. Now, remember, with the C-plan treat, we see that everyone's tissues are at different layers. It's really super important that we again use our ultrasound to make sure that we target. If they're deep fascia at 4.5, is it at 3, or is it even at times at 1? And that is different for different people. So again, for me, I'm really making sure the superficial galea is my target here. So this is the forehead on this person. Her superficial galea it says 4.5, but I almost read that, I would really target it more at 3. So it's often these more, the less deep transducer seems to work better. And again, as we move into the temple, into the forehead again, you see that you have that superficial galea is what I think works best in this area. And then in the temple, again, if I just point it out here, it is that immediate subcutis fascial structures, the retinacula, that I find the most important for creating a different texture and firmness. Yes, you want to target your superficial temporal parietal fascia, your fascial structures, but without targeting the subdermal structures I don't get the same result. So it's my priority. This is what I do most importantly. And then there's a mid-face, we'll leave that. So just a couple of little things. Optimization project. This is just a personal sharing of what I do. I put more lines in that people normally do. I basically, because for me, this whole area around to the side, that is one system. So how the lateral brow sits will give you that whole impression. So I will inject, I will do lines in the forehead, 10 to 25. I do double lining on the vector positions. So especially when I think about that lateral curve, so it's really the lateral curve of the brow, not the whole brow. I will do double angulations at different degrees of about 10 degrees. I will make sure that I'm focusing the majority of them on that point of lift. I do 5 lines then ice, then 5 lines then ice on either side. And also I respect the safety boundaries. The temple again, entirely calculated on what I want that patient to look like. And again, it's about the repositioning of tissues. So again, I do more lines generally than it would be traditionally said. I'm, as we said, really importantly, targeting the subcutaneous retinacular. Again, I do vertical, and then I do off 10 degrees for the next 5. So the first one go vertical and the next one go off at an angle, and I vector up the way, but I do stay within the safety areas. And for this, when I look at the patient, what I'm trying to work out is with my fillers, if I'm like, what is going to make this cheek flow up into the hairline? I also ask my therapy to do the same thing, except I stop at the hairline. I'd be interested to talk to you, Ashma, about how the possibilities of we would go beyond the hairline, which I have never done with my therapy. And then whether I combine them both. So we've just done hyaluronic acid in all these different continuous augmentation of direct tissue augmentation. And then I'm talking about therapy. So basically, therapy on its own would be the people who already have the structure, but you need the firmness. Thin tissue, I do volume first, and then I do therapy afterwards, but I leave it to integrate in, so I leave it for a month. If people are flying in, of course, I do them on the same day, but I do the microfocus ultrasound first. And bang for buck, the one that I think works best is if I do the therapy first, and then I do the volumization afterwards. So if this is, the timing is not an issue for my patients. So, just a little before and after, just with the focusing on the therapy around her lateral structure of her eye. We're not going to focus on it, but when we finish off, we're going to do bracing of the zygomacutaneous ligament using Intense. So this is a direct augmentation of our zygomacutaneous ligament. Just for timing, I don't really want, I feel like we've gone on a little bit now. So I do a pulse move, supporting it and not inflating that medial section. And again, I use Intense for this. I do the tear trough at the same time. And then I specifically and directly look for the zygomacutaneous ligament, ideally on my ultrasound, but if not, by feel. And that is smaller volumes, but Intense for me is the ticket for this. The product is more important than the technique here, because it doesn't expand up the tissues. Here's a little after. So we said, what was important about the mid-face? And for me, the mid-face is not a single area. And if we see it like that, we can actually make people look augmented, but not necessarily younger. And movement, structure, and support will create a sort of, it's not just that it's not spottable, is that people should look younger, but you can't really work out why they look younger. And that is largely to do with our subconscious eye as well as our conscious eye. So thank you so much. I'm going to stop sharing now, and it's been a delight.
Beautiful. It's so